Thank you so much, Sandeep, and my co-faculties in this instruction course. Thank you all for coming here. Thinking on your feet, I'll be showing three cases, three different interesting ones. I had to turn the course of events, my technique while the surgery was on. This case presented, as you can see, with, of course, very advanced kind of a cataract, and you can see there, obviously, in a case like this, you expect the nucleus to be very hard, and so was it. And in such cases, because cortex is all liquefied, the first thing is you try and fill it with viscoelastic. Then you also want to put an endocapsular ring right in the beginning, because you don't want the capsule to get sucked into your phaco tip. And that's the reason, look, I have not even done hydrodissection here. And I'm very gently putting my endocapsular ring in. And when you put endocapsular ring, the sign that everything is okay is that the end of the ring has to snap back into the back. At this stage, ideally, the ring should snap back. That means the bag is intact and the endocapsular ring is proper there. But now I realize that even after the ring is placed properly into the bag, it's come out. It's a clear indication that either I have caused a false passage or there's a PCR into which the ring has gone. So that means now at this stage, I think, should I put the ring from the opposite direction? But I start seeing the lens sinking. Then I try to push it down or push it back into place, because my next strategy is I have to get the lens on top of the capsular bag and do supracapsular phaco. But it doesn't look like. So naturally, I have no time now because the nucleus is already sinking. So I change my direction. And ideally, if I have to convert it to SICS, my standard procedure is I would do a proper scleral tunnel and do it. But here there's no time because the lens is sinking. So I make a corneal incision and then inject viscoelastic. And to my horror, by the time the incision is complete, the lens has further sunk down. So what comes to my rescue is the vectis. My job is to get it and keep it on top of the rhexis because my rhexis is intact. And once it is on the rhexis, I have time to think further, like what do I do? Now at this stage, I would want to ask the esteemed panel, Dr. VC or Sandeep, at this stage, would you still think of going ahead with phaco? No. Yeah, anything else would you? Because now that the lens is on the capsular bag, it's safe. Like, right. Would you think of lens scaffolding here?
Yeah, that could be done, but the thing is that you already made a large wound.
Yeah,
So your mind is very clear to take it out that way.
But in case I hadn't made a larger tunnel and just vectis had gone in and got it onto.
If your wound had not been so large, it would have been difficult for you to maneuver the vectors under the.
I know. Yeah, thank you.
Can I ask you a question here?
Yeah.
Why do you say the lens is safe on the capsule? Because the capsule is unsafe. The lens was sinking, so something has given way. The zonules have given way, and the lens is going. So you're dealing with an unsafe situation, relatively safe because it's on the capsule. But the capsule is unstable. It's broken.
The capsule is unstable for a long term. Right now, I can see my rhexis circular, and it has not disfigured. So I need it just to hold the nucleus.
Yeah. But the zonule, why was it sinking?
It would sink if the PC tears. See, the endocapsular ring, when I was putting, it didn't sit. That means it has caused a passage, and through that it's going down. Very often in such cases, when we have tried to put a lens in the sulcus, it has stayed there.
But Suhas,
Yeah.
you are one step away from removing the nucleus.
Yes. So, no, I was thinking in case I had not enlarged that tunnel. Like he says, if you don't enlarge, your vectis doesn't have much place for maneuvering. So now I go by the standard technique where you have viscoelastic in front of it, you have it behind, so that you can nicely, hold it and go back, and then obviously the rest of the procedure is nothing different. But I think I have put the lens. Oh yeah, and in this case, Dr. Dua, I did put the lens, a PMMA lens, in the sulcus, and it stayed there because the problem was with the capsule and not the zonules. Okay, now I had a patient who was following with me for quite some time, from as a child till she became 15 years old, and her vision gradually was dropping. It was a bilateral ectopia lentis. Every time they would come and ask, Doctor Saab, operation karegi kya? And I would tell them, as long as your near vision is good, you're a child, you're a school going kid, I will wait. And then finally she came 3 months back with vision -18 refraction with -3, and vision was 624 N10. And this is when I decided, I said I should not wait any further, and I decided to operate. Now there were multiple, decisions for me to take. I have done these ectopia lentis over years, but one thing I have realized, that for such bags which are literally pulled onto one side, is it okay on my part to put an endocapsular ring, put a segment, and pull them on the opposite side and fix them? Because these are all progressive zonulopathies. So these cases, would they withstand the kind of pressure that I'll have to put to fix them on the opposite side? Well, to do it itself is a challenge. The biggest challenge in such a case, where there's a lens coloboma as well, and the lens is literally decentered to one side, is to do your rhexis, which has to be intentionally decentered, which I did manage to do. So the rhexis was almost to one side, and I had to keep some edge of that rhexis there in case I had to fix it. And in such cases, where the capsular bag is as it is small, to get the ring in and then to get a lens in, you have to be very gentle with the bag. And till your lens is in, you still have to hold on to it with your capsular hooks. These are typical capsular hooks, and very often we tend to use iris hooks, but I would advise you strongly not to go in for. The decision making is here. Now what I have done, I have put the ring, then the next decision I had to take was whether should I fix the bag with a segment. And I was very keen not to use it, because if I had to use a segment, that would be a lot of pull. So I said, let's not use a segment. If I don't use the segment and put the lens will remain kind of decentered. But then I was all the time looking at the Purkinje images. And then what I did was, what you see here, very often you have observed that after you do cataract surgery in children, the anterior capsular, anterior capsule just opacifies. So I did lot of polishing of the anterior capsule in the pupillary area. Well, what I'm doing is little controversial. And then the next step I said, I will kind of do pupilloplasty here and just try and keep the Purkinje in the center, so that the patient will have good vision. So third day when the patient comes, patient is happy that the vision is 6/9 corrected with minimal, but on the second post-op she says, doctor, vision is good, but I see double images. Means I see a main image and I see another image. And then I say, okay, I knew why it was happening. When I did that pupilloplasty, there was a small gap that remained. And although that gap didn't look on the table, later on, it was quite obvious. So I took that patient back again, and this was it. Meaning there was a small, tiny opening there, and that was causing her the problem. So I went back and did pupilloplasty for that. And the moment that gap was covered, her double image or the second image was gone. And with the vision that she had here, she was pretty okay and happy. Now, obviously, a question comes to everyone's mind, was it okay not to put a segment and just leave her like that? And my explanation, I may be wrong, the panelists can always correct me. If, let's say, if at some stage, a few years later, I realize that no, over a period, the bag is, kind of decentering quite a bit, I still have an intact bag so that I can go with the newer segments that come and fix the bag. But for the time being, for as long as she enjoys good vision, I thought I will not disturb it. Would anyone like to add on?
I've seen these capsules fibrose very quickly,
So the exposed capsule in the pupillary area, I have polished it.
Yeah.
And let's say the bag doesn't decenter, but the capsule, opacifies, I can always make a small nick, but that will be risky because if I nick it, the future possibility of fixing the bag goes away.
And does the posterior capsule also not opacify?
See, posterior capsule can opacify any time, it will opacify. I can always do yak capsule, that is not my concern. My concern is if I can retain the anterior capsular rim, I still keep a possibility for fixing it at a later date in case it gets.
It will be interesting to see how this lens behaves over a period of time.
Yes, yes.
Because you have fixed the, back to the equator. So.
I have not fixed the back.
Oh no, okay, you just put a ring.
I have just put a ring and I have done a pupilloplasty so that,
Well, Dr. Dua can comment about that.
The only thing going through my mind is this is a zonulopathy, as you said in the beginning, and the zonules are going to continue to weaken. It's a young patient. Over time, the whole capsule, not just one segment, can pose a problem. And you might find that the lens with the capsule is sinking or dislocating because of the zonular problem. Then you have a bigger problem at hand.
But I would like to share, see, I've been practicing for the last 45 years. I have done many ectopia lentis and quite a few pseudo exfoliations. And most of the pseudo exfoliation will come, but I'm yet to see an ectopia lentis, even after 20 years, coming back with a lens bag complex dropping down. They don't drop down.
I've done aniridia patients with cataract and then put an aniridia lens in the bag. And many of them, not many, but at least 3 or 4 of them have come with the whole capsular lens in the vitreous. And I've seen this referred to me in other cases that have come as well. Then you have to fish out all of that and do a scleral sutured lens in those patients. So maybe the pathology is different in these.
No, this we have seen all the time with pseudo exfoliations. So BC, do you remember seeing any of these ectopia coming years later with bag lens complex?
Exfoliation, yes, but not
Yes,
the ectopia. But I think in your case, the pupilloplasty is going to help the patient for a long time.
Yeah, that's
so
right.
little bit of decentralization.
I'm prepared, I felt, for next 10 years of a good vision because the technology keeps changing. You can always go and redo it.
I have one question for you, Suhas. Is many of these ectopia lenses I've seen, post-operatively years later, they have many vitreoretinal pathologies, including RDs happening. So does the pupilloplasty restrict the view of the fundus?
Pupilloplasty today is to give him better quality of vision. Tomorrow, if I do not want it, tomorrow I want to do VR intervention, I just have to put yak. And the reason I did this was, let's say the only other option for me, if I didn't want to put a segment, was to remove that bag and fix a lens. That means I'm already entering into that posterior area. And here, you're not done vitrectomy, you're not entered into posterior segment, and still patient is 6, 9, enjoying the vision. And I'm sure he'll enjoy for another 10 years.
My other thing which I do sometimes, which I have now realized for ectopial lenses, is I always put the lens in the sulcus and then capture it under the anterior capsule.
Okay.
Because, I think the sulcus is a rather safe way to put the lens, and it avoids decentration, which will happen when your lens is in the bag with a progressive zonulopathy.
For that, yes, but for this, where the lens is already shifted up, the bag is already shifted up, putting it into the 3-piece into the sulcus and fixing it, the lens would also go up. But anyway, that's a good point. We have time. No? Okay. So with this, I end my talk.